Diuretics. This is Dr. Paul. Thank you very much. Today I want to talk about hypernatremia, and as always I request you to visit my website at www.drpaul.org, where we have been posting nowadays almost daily videos, and I am sure that you will get something out of them. Today, basically, hypernatremia. This is a common problem, and I will give you most important points first. First, define it. Hypernatremia is the sodium concentration more than 145 milliequivalents per liter.
DSU physical in room 1.
Room 1?
He goes to Phoenix, and they need a letter stating that his blood pressure is okay. Their okay blood pressure is 150 over 100. I got 136 over 100.
136 by 100.
Yeah.
So that's not qualifying, right?
No, 150 over 100 is the highest that they can go. I got 136 over 100.
So he qualifies?
So it qualifies, yeah.
Okay.
Just wanted to let you know what was going on.
All right, thank you. So basically in hypernatremia, you need to differentiate the causes. You see, yesterday I was talking about hyponatremia, where there is isotonic hyponatremia, hypertonic hyponatremia, hypertonic hyponatremia. But in hypernatremia, usually it is hypertonic because the osmolality is high. Most commonly, hypernatremia happens when there is a lot of water loss and also when there is a salt gain. And body responds to hypernatremia by thirst. It tells you go and drink some water because there is water loss causing the sodium to go high. When the sodium goes high, serum osmolality goes high, and serum osmolality, it acts on hypothalamus and makes it to produce more ADH. And ADH, as you know, it is antidiuretic hormone, and it retains, it causes the water retention, and also that thirst mechanism helps the patient to drink more water. So you see, the mechanism is very, very simple. So remember that hypernatremia is when sodium is more than 145 milliequivalents per liter. And unlike hyponatremia, this is always hyperosmolar state with cellular dehydration. Because it's the excess of sodium, but water is going down because of water loss. The fluid loss, it could be a pure water or hypotonic fluid, but either way the body is losing the water, and sometimes even iatrogenic causes. Sometimes medications causing diabetes insipidus. What happens in diabetes insipidus is that body loses water. Again, hypernatremia is happening because of the loss of water in diabetes insipidus. So now let us talk about the different causes of hypernatremia. Number 1, water loss. Water loss, how could this happen? Not enough water in the body. Just think of that. You can make up your own list actually. There are when we are not drinking enough water, you can say that as a cause. And there is diabetes insipidus, I said, whether it is central diabetes insipidus or peripheral, that is nephrogenic diabetes insipidus. And also, how can you lose water from the body? Diuretics, whether loop diuretics or osmotic diuretics. You are losing fluid from the body. What other causes can you think of? Kidney disease, interstitial kidney disease. So you are losing water from the body in these cases. And in non-renal causes, come in.
It's just a pre-appointment physical in room 3. Dr. Paul, would you like me to put his chart outside his door?
Yeah.
All right, thank you.
Thank you. So the other things are, there are also non-renal causes, like when you are vomiting or diarrhea, excessive sweating. So those are the non-renal causes of hypernatremia. Basically, low water in the body. Think of all things you can. Those are the causes for hypernatremia. Now, urine osmolality plays a very important role in the classification. When there is like 250 milliosmolar per kg, urine osmolality less than that, or more than 400 milliosmolar per kg. I will describe that in more detail in a minute. But the point here is the body is losing water, whether pure water or isotonic fluid, or in any way. It can happen in any way. Like I said, osmotic diuretics like lactulose, mannitol. You see, what lactulose does, it causes osmotic diarrhea and the body loses fluid. So lactulose can cause hypernatremia. You can think of renal causes. Like I told you yesterday that severe hyperglycemia can cause translocational hyponatremia. But hyperglycemia can also cause glycosuria. And in glycosuria, glucose and water, you are losing both of them. And again, water depletion, hypernatremia. So you see, folks, this hypernatremia, osmolality, it could be less, it could be high, depending on whether it is a renal cause or extra-renal cause. So urine osmolality, you have to use urine osmolality to determine whether it is a renal cause of hypernatremia or extra-renal cause of hypernatremia. And we have diabetes insipidus. There is central diabetes insipidus when the body does not produce adequate ADH. There is also nephrogenic diabetes insipidus when the kidneys are not responding to the action of ADH. Either way, the body is losing the fluids, low volume, water depletion, and the patient is developing hypernatremia. There are drugs like lithium, demaclocycline. These drugs can cause diabetes insipidus and can cause hypernatremia. So you see, the list goes on and on and on. So I don't want to spend a lot of time in that area, but let me talk about treatment. Treatment is very simple if you understand the etiology here. I am telling you that the water loss is the main problem. So you need to think about how to give water. And the brain cells, the very important thing, let me describe this, very important. What the brain does is, as the dehydration happens, the brain produces osmoles. And these osmoles, they are called idiogenic osmoles. These osmoles, they cause intracellular water shift. So these osmoles, they start to work on the body and the water goes inside. What is happening? Hypernatremia is developing outside. And once you give the fluid to these patients, they will develop severe neurological impairment. So hypernatremia should be carefully treated. Yesterday we have talked about hyponatremia, its treatment. You should not rapidly treat hyponatremia. The same, why? Because it can cause central pontine myelinolysis. The same thing here. In hypernatremia, rapid correction of hypernatremia can also cause neurological problems. So let me make it clear, folks. Rapid correction of either hyponatremia or hypernatremia is dangerous. So hypernatremia, you need to treat it over like 48 hours, like 1 milliequivalents per liter per hour, just like in hyponatremia. I mean, there is no consensus here. I mean, we can start a civil war among doctors if we start a debate on about the rate of treating. And there will be fights, there are conferences on this, and there are fights in the conferences arguing about how to treat hyponatremia and hypernatremia. But the point is rapid correction. One thing everybody agrees is rapid correction causes severe neurological problems either in hyponatremia or hypernatremia. So what we are understanding here is hypernatremia. Okay, hypernatremia, again the volume status is important. Hyponatremia volume status is important. Hypernatremia volume status is important. Based on that, there are three types again here: hypovolemic, euvolemic, hypervolemic. So there is hypovolemic hypernatremia, euvolemic hypernatremia, and hypervolemic hypernatremia. So the treatment is very simple if you think in that classification. If it is hypovolemic hypernatremia, that itself is saying there is less fluid. So you got to give fluids to these patients. And you should always start with normal saline, because you see, even normal saline is hypoosmolar compared to plasma. So you start giving normal saline up to 1 point, and then you give half normal saline or 5% dextrose, like that. So hypernatremia with hypovolemia, you give fluids. Then secondly, hypernatremia with euvolemia, that means fluid status is good. In these patients, how to get rid of sodium? You can use a loop diuretic. Using a loop diuretic, the body gets rid of sodium. The problem is the body will also get rid of water, which is essential, making euvolemic patients going into hypovolemic. So as you give loop diuretic to these patients, even though they are euvolemic, you need to give them fluids to prevent dehydration and hypovolemia. So very simple. If there is hypovolemia, give fluids. If it is euvolemia, give a loop diuretic, and give fluids if there is risk of dehydration. And finally, hypernatremia with hypervolemia. When there is hypernatremia with hypervolemia, there is so much fluid. So you got to get rid of the fluid here. Then loop diuretics. And
just need you to sign for physical. Thank you.
I'm coming soon. So basically here, hypernatremia with hypervolemia, you need to get rid of sodium and water, right? Hypernatremia, high sodium, hypervolemia, lot of water. So you need to get rid of sodium and water. How can you do this? There are only two ways. Either you diurese them or dialyze them. Those are the only two things. Either you diurese them using a loop diuretic, or you dialyze them if there are severe neurological problems. Then you need to immediately send this patient to dialysis. So what we are seeing here is the treatment, acute hypernatremia. I mean, sometimes patients develop dehydration immediately. Then you need to calculate weight loss, and that's a good thing to calculate the water deficit, and you need to treat that water deficit using 5% dextrose or normal saline. But if it is a chronic dehydration, then you need to be careful. You see, 60% of our body is water. So 60% of human body is water. So you got to give a lot of water to patients with chronic dehydration, especially a grandma or grandpa an elderly patient living by himself with no good access to water, they develop chronic dehydration and hypernatremia. So these patients, you need to treat their volume loss gradually, because as I said, rapid correction is more dangerous than the treatment, than the disease itself. So those are the most important hypernatremia points, and hope you got something. Please visit me at my website. Thank you very much. Have a nice day.